Now you can give the countdown. You can unmute yourself and. So Manoj, you can hear me?
Yeah. We are live now, sir.
Thank you very much, OrthoTV, Ashok, Shyam, and Neeraj Bijlani for providing this wonderful platform. And we are so fortunate today. We have a topic of FAI, the femoroacetabular impingement, a topic which probably most of us have lesser understood, has a lot of questions, whether the condition does lead to a lot of problems in future, whether the conservative treatment is feasible, whether it every time needs surgical intervention, and what is the best strategy to manage. So there are a lot of questions in mind regarding this condition. And we are fortunate that we have two faculties with us, Dr. Harshwardhan Jain, radiologist from Nagpur, and Dr. PRASAD GOURINENI. So may I invite Manoj to please introduce our faculty members?
So very good evening to all of you. So first of all, I would like to introduce our main faculty, Dr. PRASAD GOURINENI. He is from USA. He partly works in USA and partly at Tirupati. He is a visiting surgeon even at Mumbai hospitals. He is basically an hip arthroscopy and hip osteotomy surgeon. He works specialized in pediatric orthopedic problems, spine deformities, hip joint preservation, sports medicine, and trauma. He doesn't need more introduction. He has been faculty to many hip preservation, hip osteotomy, and hip arthroscopy courses before. So we didn't hear much about this topic about the femoroacetabular impingement, the hip impingements, which we commonly come across. So we'll be hearing it from Dr. PRASAD GOURINENI. And the other faculty is Dr. Harshwardhan Jain, who is a well-known radiologist from Nagpur. He has got a special interest in musculoskeletal radiology, and he will be dealing with few of the interesting cases and the MRI presentations of this hip impingement. I think first we'll start with Dr. PRASAD GOURINENI. We'll be dealing with how to read the normal or routine pelvic X-rays.
Yeah.
All right. Thank you very much.
Yeah, you can go to your presentation. And also we welcome Dr. Alok Umre.
Good evening, sir.
Good evening, welcome.
All right. Is my
yeah, we can see
visible?
Yeah, it's visible. You'll have to just make it full presentation.
All right. Everything good?
Yeah, looks good.
All right. Good evening, everybody, and thank you, Dr. Doctors, for inviting me. Dr. Chandak.
Most welcome.
Yeah.
Yeah.
So I'm going to talk about what I see on a pelvis X-ray. We're not going to talk about tumors, infections, arthritis, and other things. It's more for mechanical morphology of the hip, right? The shape and size, what's normal, what's abnormal, and what can cause problem, right? So standard pelvis X-rays here. A lot of people call it normal. Even I'll say it's normal if clinically this patient does not have any problems. There are quite a few variations in the hip, right? You can see the ischial spine.
Yes.
You can see the anterior wall covering the head a lot. Posterior wall somewhat deficient. But pay attention that this is the inlet view. So a lot of things have to be looked at. So we're going to spend about 10-15 minutes trying to understand what's ideal. I don't know what to call it normal, but ideal, and then what's deviation, and try to understand the clinical application of these variations. So for me and for most people, a pelvis AP is the most important image of the acetabular. Femoral head and neck, you can see it on any hip X-ray, not any, but any AP X-ray. But pelvis, whole pelvis is important because you have to see how the pelvis inlet, outlet, or rotated or tilted before you can comment on the acetabular shape. So what's a perfect AP pelvis? Perfect AP pelvis is with no rotation of the pelvis, You keep the feet internally rotated so that the femoral neck full length is visualized. That's what trochanter becomes less obvious. Then the tilt of pelvis on the X-ray, we measure the distance from the sacrococcygeal junction to the top of the symphysis, right? Professor Gans gave these numbers at 2 to 3 centimeters in males and 2 to 6 in females. I'm going to say just stick to that 2 to 3 centimeters for an ideal X-ray. Males or females, it's anatomy we're going to look at. So 2 to 3 centimeters is a good number. Then you want the beam centered in the middle of the hip so that you can see both hips, middle of the pelvis, so you can see both hips. One thing you cannot adjust on computers, anything else, is the exposure has to be good where you can see the acetabulum walls. The acetabulum basically is the anterior wall and the posterior wall. So you need to see those walls well. Everything else you can adjust with some experience, but if you can't see the walls, you can't read a pelvis acetabulum X-ray. There's little controversy about supine versus standing. A lot of people say they'd like to see a standing X-ray because that's more important functionally, how they're behaving, how the pelvis is tilted. But I say standing is more important if you're going to stress the hip, like in dysplasia, that you can see subluxation better if they're standing. The functional position of the hip, based on how tired you are, the pelvic tilt can change. If somebody's tired, there'll be increased pelvic tilt. So I don't think that the functional position is a fixed position. It can change with your muscle strength, activity, morning and evening of the day. Structure of the pelvis is seen in both. But for me, it's easier to get a perfect AP view. I can control the tilt, rotation, and everything else perfectly on a supine X-ray. So because you can see the structure anyway, that's all you're going to look for on the X-ray. AP supine is what I get, though there's a lot of people who want to get a standing X-ray. This patient has no hip problem. This is my first patient where I'm going to do a pelvis AP study to see how many people have variations on an asymptomatic patient. I didn't get a second X-ray on anybody else because I understood that I need to get IRB and there's radiation involved. So this is the first patient I ever got. He came for a hand problem and I convinced him to give me a pelvis X-ray. No hip problems at all. But this X-ray looks pretty normal, but the distance is probably a little increased. A little bit of inlet, right? His head looks very round on this X-ray, but there are some signs I'm going to show you, teach you to look at to say that it's probably not very round. And there's a small crossover sign, right? We'll learn about all these things. This is not a good X-ray. This is both tilted and rotated. Tilt is easy to adjust. You rotate the film around a little bit and you can get the tilt corrected. But the rotation takes some more time of some experience really to understand the effects of rotation. This is an outlet view. See the distance here is very little, big arterial foramina. So what this does is the outlet view will make the posterior walls look more conspicuous, more covered than the head, and anterior wall is less. Ignore the little bullet in the right hip. So with that background, if you get a perfect pelvis AP X-ray, these are things you look for. There are only 3 things in an acetabulum you look for. The sourcile, that's the top, the eyebrow, the sclerotic dome of the acetabulum. The sourcile has size, shape, and inclination, 3 parameters. There is the anterior wall, there's the posterior wall. You keep in mind that any subluxation decreases the femoral head coverage. So it's not very accurate to call coverage deficient if the head is subluxated, though it's uncontained. There's this signs called ischial spine sign, crossover sign, and teardrop shape. These are indirect signs. I'll try to tell you the importance of those as we go on. So back to our normal pelvis X-ray, the patient who agreed to let me do a pelvis X-ray. You all know this, iliopectineal line for the anterior column. Not very important in hip preservation. Ilioischial line, we call it Kohler's line, K-O-H-L-E-R, Kohler's line. This is a parameter of the pelvis to which the hip is measured against. The distance between the head and the Kohler's line is ideally supposed to be about 10 millimeters, 5 to 10 millimeters. Less than that means the head is too close. That's more like a deep acetabulum or getting to profunda. If the head touches the Kohler's line and crosses it, it's called protrusio. That's the definition. But the distance increases here, That's more like dysplastic and subluxated femoral head. The Kohler's line tells you where the head is in relation to the pelvis, or the whole hip joint is to the pelvis. That's the sourceal. I don't know if you could see it or not. I drew the line. I didn't draw the line all the way to the corner here because the sclerosis stops at this point. Do you see my arrow?
Yes, we can see that.
Okay. So I stopped here because the sclerosis stops here. This is extraarticular ilium. So we keep adding these extra bone, the measurements go up a little bit by a few degrees. So to be accurate, you should stop where the sclerosis stops for the sourceal. An important thing to pay attention to. This line is in the center of the primary compression trabeculae of the femur. This is where the primary stress of the hip comes through. So right in the middle is a mechanical line coming through all the stresses, right? Look at the relation between the sourceal and the primary line, the stress line. The sourceal is perpendicular. It's centered equally on both sides, right? The sourceal and perfectly concave on a convex head. That's an ideal sourceal to femur relationship. Right? So the primary stress of weight bearing is coming and it's very well balanced by a sourceal that's perfectly positioned on top of the head. That's anterior wall. How do we say it's an anterior wall and not the posterior wall? Anterior wall has a gentle curve to it. It's S-shaped, a gentle S. You may argue with me saying that it's not an S, it's a C, but whatever. Take it from me. It's a gentle curve like this. And the anterior wall always goes to the bottom of the superior pubic ramus. Here's the posterior wall, a little more straighter. Here it looks like a S shape here also, but it's usually more straighter, more vertical, and goes to the lateral aspect of the ischium. So if you don't know which wall it is on top, look at where it's starting in the bottom. When you look in the bottom, posterior wall goes to the ischium, anterior wall goes to the pubis. Okay. And here, the anterior wall is extending lateral to the posterior wall. That's called a crossover sign. So crossover sign is never normal, but doesn't have to be pathological. So let's try to understand normal versus pathological, right? Variation from a perfect normal X-rays are very common, but they're not significant unless they're causing pathology. So we'll talk more about variation, but so here's a crossover sign. Some people call it a retroverted acetabulum, but again, I'll explain to you that there are other types of acetabular that have a crossover sign. Crossover sign just tells you that the anterior wall is covering more head than the posterior wall on that particular film in the hip. So ideally, the anterior wall and posterior wall should contact each other at the top of the sourceal, so they never cross each other. That's a teardrop. So teardrop is a U-shaped structure. A wide teardrop is usually indication of dysplasia, and a narrow teardrop is for coxa profunda or protrusio. But you don't need the teardrop shape to really say somebody covered, well covered or overcovered or undercovered. The teardrop can be narrow, even in dysplastic sometimes. The teardrop can be wide in overcovered people. So teardrop is just an indirect sign. You look at that and then start measuring the coverage. And when the coverage is adequate, ignore the teardrop. And then there's I'm not saying that I see it here, but that's the ischial spine sign. Ischial spine sign means that the ischial spine is projecting into the epipelvis. That means that the acetabulum or this whole ilium is retroverted, or the whole hemipelvis is retroverted. That means the ischial spine projects inside. But you can see the ischial spine in an inlet view. This is an inlet view because the distance is increased here in the sacrococcygeal junction of the pubic ramus, the superior pubic symphysis. Normal 2 to 3. This is almost like 4 to 5. So that may be causing the crossover sign and the ischial spine sign. Here is another example. Okay, here we're measuring some angles here. A vertical line from the center of the head, and then from the center of the head to the lateral edge of the sourceal. Again, look at, I left a little bit of bone lateral to it because the sclerosis stops here. That's extraarticular. So this is a measurement called LCE, angle of fiber, lateral center edge angle, Ideally, about 25 to 40 is a good number. More than 40 is over coverage, and less than 25 is dysplastic. This most people know, the lateral center edge angle, but the less common knowledge is a medial center edge angle. The sourceal needs to be adequately covered on the medial aspect also. I'll show you examples of medial dysplasia later on. So typically, this is also about 30 degrees. About 25 to 40, again, probably is good, but 30 on each side is a good establishment. So 60-degree arc of the sourceal with 30 on either side of the center is a good acetabulum. More than that is too much, and less than that can be dysplastic. And the pelvis, here I'm drawing the line, transverse line. This line can be anywhere. We're drawing it from one medial sourceal to the other medial sourceal edge. And the second line I drew just now is connecting medial sourceal to lateral sourceal. So the angle between the horizontal to this line is the sourceal angle. You can see it's upsloping a little bit. So normal is 0, flat, to about 10 degrees upsloping. More than 10 degrees is more dysplastic. And less than 0 will be negative. It's not healthy either. What happens if your negative sourceal angle is the head has a tendency to move more medially. You may say, what's wrong with going medially? When you go medially, you start loading the medial non-articular structures of the head. The fovea, the ligamentar teres get compressed against the acetabular fossa. Laterally, you're upsloping, the head wants to translate laterally. That's dysplasia, and you get lateral subluxation. So remember that thing I showed you, the vertical line. The vertical line is nicely centered, and this is perpendicular. There won't be any medial or lateral stresses. But if it's not, and then you get medial subluxation or lateral subluxation. This is the central line to the edge. I'm showing you again the 60-degree total arc of the sourceal here. Right? This is the total arc. About 60 is healthy. This is an example of a negative sourceal angle. Right? What you see here is, again, the central edge angle is increased. The lateral coverage is increased. This patient may have impingement. This almost looks like about 50 degrees, overcovered. That's the sourceal angle. Very deficient medially, and it's upsloping. So reverse sourceal angle and medial deficiency go together. Right? Unless you're deficient medially, you can't have a reverse sourceal angle. So reverse sourceal angle here, this patient came with hip pain. The head is migrating medially. It's about to touch the acetabular fossa, but the ligamentar teres and fat in between that are getting crushed, and this patient has pain from a foveal impingement, negative sourceal angle. And that's his MCE, very little medial coverage. Sorry. Does it make sense? Any clarifications on that you need?
Just wondering how much we have to read on a pelvis X-ray, which routinely we might not be noticing many a times.
Right. So basically, idea is if somebody doesn't have any pain and it's a trauma case, you don't need to pay attention to any of these things. If somebody comes with somewhat hip-related pain, younger person, and it's probably important to look at these, learn them, or refer to somebody who has interest in these.
Yeah, Asim Negi, your comments on radiology of X-ray. Are we every time reading all those things?
No, not at all. Right?
No.
Oh, I'm sorry.
So yeah. So this we need to read specifically in X-rays, non-trauma, no infection, and when patient has hip pain or limitation of movement, we'll be doing
Unexplained pain.
unexplained pain. Yes. Manoj, your experience?
Yeah, we don't draw all these lines, and sometimes may not be looking at all these things. But if the diagnosis is not certain, then I think this could give more clue. Yeah.
Yes.
Also, then this negative sourceal angle, we have never ever thought of, like what sir told us about negative sourceal angle.
Yeah, that's a good knowledge addition, because negative sourceal angle, I think we have not noticed so far in any of the plain X-rays. Harshwardhan, your observations, Harshwardhan, if you are there.
Sir, we find MRI much easier to read than these X-rays after going to these lines and all. It's much easier to read MRI.
Okay, but it's right.
Anyway, luckily, negative sourceal angle is not common, but it's important to pay attention to it if you're going to treat hips to preserve them. Right? And also, if you start paying attention.
Yeah, just one interruption. What is the implication of high fossa? Somebody wants to know.
Yeah, that means that you have medial deficiency. The high fossa means that the acetabular fossa, instead of ending down here, here in this patient is coming all the way up. That means there's no cartilage in this area.
Okay.
The cartilage is only from here to here.
Okay.
So there's medial dysplasia in the acetabulum. So this patient will have pain from head loading acetabulum without any cartilage. that
Yeah.
causes medial osteoarthritis. About 10% of total hip people do are for medial osteoarthritis. The importance is medial osteoarthritis is not easily diagnosed, especially if you're not aware of it, right? You'll miss it. And somebody may have good joint space laterally, and you don't want to do a total hip on them, but they have bone on the medial aspect. So start paying attention to medial osteoarthritis.
Okay, perfect. Thank you.
How do you calculate the joint spaces over here, like the joint space widening or the decreased joint space?
Right. So the sourceal to head is where the real joint space is, where the cartilage is really, right?
Okay.
There's no real joints. We talk about medial joint space, but the line between the space between the ilioischial spine and the ilioischial line and the head is usually fat and ligamentum. So this distance decrease, that means the head is medialized, medially subluxating. The head, this distance increase is laterally subluxating. So that's not really joint space, though we call it joint space. The true joint space is between the sourceal and the head. And healthy is probably 3-4 millimeters, right? And then less than 2 is not good enough to do any preservation. If somebody has narrow joint space with not even 2 millimeters, it's a contraindication to do preservation. That means there's too much damage.
Okay, perfect.
Okay. And also I look at the space, is it uniform or is it more wide laterally than medially? That also has implications. Somebody with cam impingement will have a wider lateral space than the medial side of the sourceal and head space. Okay.
Okay.
All right. So now just one slide on dysplasia. Sorry, this is reversed. So you can see clearly the femoral head here is subluxated. The space is wide. The teardrop is a little wider than the other side, right? The head is clearly subluxated. The central triangle is less than 25, probably more like 10 degrees. Half the head is uncovered, right? Normally 80% of the head should be covered by the sourceal. 80% is ideal. But 70 or less is dysplasia, and more than that is overcoverage, more risk of impingement. Then the sourceal angle is elevated here. So this is a classic dysplastic hip, shunt spline broken, medial space wide, head is subluxated, sourceal is steep, there's coxa valga, and the head is also in little valgus related to the neck. Caput valgum, head valgus, neck valgus. So this is a classic, has everything that puts this patient at risk for dysplasia and subluxation. And keep in mind that most dysplastic, 1/3 of dysplastics have a crossover sign. So crossover sign is not a sign of retroversion. Even dysplastics can have a crossover sign. And cam morphology is very common. A spherical femoral head is very common in dysplastic because the socket was never deep enough to mold the femoral head. So the femoral head and the acetabulum need each other to mold into a good shape. The femoral head is not contained adequately in say a 5 to 10 year of age group. In the age group, the head won't be round. They may have a spherical femoral head. So with that introduction of the acetabulum, the femoral head coverage, ideally the sourceal should cover 80% of the head. The posterior wall should cover 50% of the head. The anterior wall should cover 20%. And the posterior and anterior wall should not really cross over. That's ideal or normal. People talk about acetabulum version of 15 to 20 degrees, and they use CT scans to measure it. It depends on where you measure. Some people say they'll always measure the middle of the head. Then obviously most people will be antiverted, 15 to 20 degrees. But there's cranial overcoverage or retroversion that we miss if you look at CT scan. So a pelvis X-ray gives you a global picture of the acetabulum morphology. So I rely on pelvis X-ray to look at the acetabulum than a CT scan. Sourceal size, right? I showed you the sourceal size of 60 degrees is ideal. And if the C angle medially is decreased, then you have a high fossa, right? That's medial dysplasia. And if lateral side is decreased, it's lateral dysplasia. Now, if it's less than 20% of the femoral head covering the anterior wall covering the femoral head, that's the anterior wall deficiency. Less than 50% covering the head, the posterior wall covering the head, that's the posterior deficiency. More than that, more than 50 will be over coverage, and more than 20 here will be over coverage. Right? We'll look at more X-rays as we go on to understand this. And the coverage percentage is more at the center of the head or neck axis. Draw neck axis right in the middle, and at that level, posterior wall should cover 50%, anterior wall should cover 20% of the femoral head. Version we talked about sourceal size about 60 degrees, sourceal angle 0 to 10, like I told you already. And sourceal shape should be nicely concave, matching the convex head. Head is convex, so it should match. So what happens if you're not perfect, right in the middle? The head coverage less than 70, that's dysplasia. C angle is less than 24, it's dysplasia. Increased anteverse of the femur or the acetabulum, that's anti-deficiency, the anti-dysplasia. The sourcial angle is more or equal to 11 degrees. That's higher than normal sourcial angle, that's dysplasia. So you have a narrow normal in the middle, 80 to 90% normal, 25-35 for LCE, 10 to 20% anteversion, 0 to 10 degree sourcial angle. Anything more than that is over coverage and a risk for impingement. Not diagnostic for impingement, but a risk for impingement. So one little mention about immature hips. In pediatrics, crossover sign is a norm. Somebody under 12, 13, where the fibroid cartilage is not closed yet, they'll always have a crossover sign because the posterior wall is not fully ossified. They'll have a false crossover sign in a pediatric patient. Even for trauma, somebody has a little, not little, but a posterior wall fracture. You may miss it completely because it can be all cartilaginous. So we actually wrote a paper with a few cases and said that MRI is essential as a post-operative, post-reduction tool, imaging tool in pediatric hip dislocation. Otherwise, you'll miss posterior wall fracture altogether or underestimate the small fleck-like posterior wall fracture. So knowing that the anterior wall can be undercovered, normal, or overcovered, and posterior wall can be undercovered, normal, or overcovered, there are 9 types of acetabular, 9 morphological variants. Only one is normal. But none of these are pathognomonic of any disease unless there are other signs like symptoms, clinical signs, especially for impingement. Impingement is not a radiographic diagnosis, it's a clinical diagnosis, but you need to know the risk factors. And I'm showing you the underlined 4 have crossover sign. Okay. I'll explain that more with cases.
Yeah.
So crossover sign can be from anterior overcoverage, posterior deficiency. That's true retroversion. So we should call everything retroversion with this crossover sign. With anterior overcoverage and posterior deficiency, that's true retroversion. And the ideal treatment is you want to turn the acetabulum anteriorly, antiverting PIO. If anterior overcoverage and posterior is normal, that's anterior overcoverage, that's all. You don't want to turn the acetabulum or do anything else. You just want to remove some bone from the anterior wall, anterior rim reduction, and suture the labrum back. So totally different treatment. If the anterior and posterior both are overcovered, that's more like profunda and protrusia. There, your options are, if there's no medial dysplasia with lateral overcoverage, then you can do a rim reduction. But if there's medial dysplasia, you want to do a reverse PIO. It's not the same as antiverting PIO. You just want to reverse the slope of the acetabulum. Negative sourcial angle becomes more flatter with the periacetabular osteotomy. PIO is periacetabular osteotomy or a triple. In any osteotomy will work. You have anterior and posterior deficiency and still have a crossover sign, then you do a standard PIO. Right? So this will never get a PIO, but all the other 3, not other 3. These 2 are always PIO, and this is based on whether you have medial dysplasia or not. Is that clear enough?
Yes, sir.
Yeah.
All right. Thank you.
So
Right.
many types of hip. I think we never thought and pondered that only one is normal and there are so many varieties of abnormalities of the coverage of head.
Right. But keep in mind that you don't need to treat them unless they have clinical symptoms and you made a clinical diagnosis.
Yes.
Right. So here's a case example here. Little bit of inlet, but a lot of posterior deficiency and anterior overcoverage. That's a retroverted acetabulum. Clearly retroversion, right? And big crossover sign. Here is a small crossover sign. A little overcovered even in the back, but it's mostly anterior overcoverage. Right? Sourcial is good, posterior wall is adequate, and anterior overcoverage. This is an example of anterior overcoverage. The treatment here will be to remove some of the anterior wall to relieve their impingement. If they're impinging. If they're not impinging, obviously this will be a normal variant. It's not considered abnormal anymore. This is an example of, well, you can't call it protrusio, but this very deep acetabulum, Head is 100% covered by the source field. Anterior wall is covering almost 80-90%. Posterior wall is covering 100%. There's a crossover sign. But there's no medial dysplasia. And this patient can get a lot of rim resection. You can excise all this acetabulum and make it shallow and cure their impingement. A few other little examples here. You see the AIIS, little prominent, but on the right side, this patient developed an avulsion fracture. Didn't displace a lot, but still there's a little fracture. And this can heal with callus and become more prominent and can cause impingement between the AIIS and the femoral neck. They don't touch each other, but they squeeze everything in between with hip flexion. So it's a risk factor for AIIS impingement. Now I'm going to go to the femur. The normal femur is nearly spherical, right? A round head is essential for good range of motion of the hip. A spherical femoral head don't move very well. They may have flexion extension, but they don't rotate very well. So in the femur, you're going to look at the shape and size of the femoral head. You look at the physeal line. If the physis is open, you can look at the physis, but the physis is closed. You can see a scar of the physis. Look for the fovea. Fovea centralis, where the ligament teres attaches. You can see it often. Look at the head neck offset. Is the head neck contoured correctly? Is there any bumps or lack of concavity at the head neck junction? Then look at the neck shaft angle. You don't need to measure it, but I'll show you how you can look at coxa vara and valga more by eyeballing. And then the neck length is ideally 1 femoral head diameter. From the center of the head to the tip of the trochanter, it should be 1 femoral head diameter to have an adequate neck length. If it's shorter than that, it's called coxa breva. So longer than that, I've seen a couple of cases with very long necks. I don't know if we call it coxa longa. It's not really a problem unless the neck starts breaking, because they're more at risk of neck fracture. Here is our hips that can pass as normal, but you can see here, I couldn't get this off, but this blue line represents the sagging rope sign. When I was a resident, sagging rope sign had a lot of theories as to why it happens, but sagging rope sign is essentially an outline of the femoral head, usually anterior femoral head. When it goes so far into the neck, it's a sign of cam morphology. That's a growth plate scar. This comes all the way down here. So that's an aspherical femoral head. You can see the asphericity on AP view, right? There's no concavity up top, but it's a sign that there'd be anterior cam also. And this side is the physeal scar on the right side. This physeal scar is not quite normal because it's extending onto the neck, again causing cam morphology. So both these are signs of cam morphology. That means the head is not round in a different plane. All right. So back a normal pelvis X-ray. So instead of drawing the neck shaft angle, look at the tip of the trochanter, the relation to the center of the head. If the tip of the trochanter is very close to the center of the head, that's healthy. If it's too high, that's coxa vara. Too low, it's coxa valga. Because the neck shaft angle measurements vary with the rotation of the pelvis, the X-ray. With the lesser trochanter prominent, this femur is antiverted, so the neck shaft angle always will look higher than it truly is. Again, showing the relation of the source seal to the axis. Here you can see, do you notice that the head has a nice round head coming to the neck, right? There's no bump in the back. That's a nice round head. But look in the front. There's no concavity. It comes like a straight line and a little bump and then goes down. So that's obvious cam morphology, a little bigger on the right side. That's cam morphology, not cam impingement, cam morphology. So how do you measure the asphericity of the head? So you put a perfect circle on the head. The point at which there's extra bone going beyond the circle is where the concavity or convexity of the head ends. That's the head neck junction. I call it alpha point, right? That particular point is alpha point. So you draw the neck axis on the X-ray.
So if
Alpha point to the center of the head, this angle is called alpha angle. Alpha angle tells you how spherical the head is, right? The alpha angle is very low. That means the head is coming to be a nice round sphere all the way down to the neck. But 45 degrees is healthy. More than 50 is probably cam morphology. Not cam impingement, but cam morphology. And this one is close to almost 80 degrees, right? So the sphericity starts way medial, and this is a higher risk for impingement. Here the head looks very round and nice, but the facial extension sign. which means that the cam is somewhere here. You need to get that oblique X-ray or a CT scan really to see it. And here again, the official scar is the head extending out of the neck. That means there's cam here. You can see some cyst formation also on the head. That's called herniation pit or an impingement cyst. Those are signs of actual impingement happening, right? These little areas. And the person with the obvious cam here, official extension. There's a little groove, no concavity of the head, of the neck, right? It's a straight line going across. There's an impingement groove.
So cam can happen on only one side of the head?
Pardon?
Cam can happen on one side of the head? My understanding is...
Yeah, it's almost always in the front. Posteriorly, I haven't treated anybody with posterior cam. I've seen it in osteochondromas and things like that, but it's not common to have a posterior cam.
Okay.
It's a lateral or anterior anterolateral.
Okay.
Because impingement inflection.
Are they always?
Pardon?
Are they always symptomatic?
No, that's why I said no cam impingement. Cam morphology is very common. Just understand that it's a morphology, but don't treat it unless they're correlating with clinical exam. I'm going to cover the signs of impingement and how to diagnose impingement in my next talk. And here's an obvious bump you can see, right? A spherical head is all obvious. Just one X-ray to say that this is skeppy, lift epiphysis. The metaphysis is causing the impingement with the fragmentation of the metaphyseal bone. And here its cam is covered with cartilage. So they're different. They're not the same. This looks like a skeppy, but look at the varus coming in the neck. And the head is not in varus to the neck. So this is not really a skeppy, but a variation of developmental coxa-vara. You pay attention. See this angle here, it's not into varus. The facial line to the neck shaft is almost perpendicular. And then lateral, it looks like a skeppy, but there's no posterior tilt really. Not that much posterior tilt. There's more posterior tilt on the other side than this side. So this is not a skeppy because you can't do a neck osteotomy at this level and correct this. So it's important to distinguish between lift epiphysis and this type of coxa-vara. So a little summary again. That's the sourceal total sector. That's the fovea. Yes. So important to see the fovea. The fovea should not be touching the sourceal. The fovea should be medial and lower than the sourceal. Fovea is high. It's going to engage the sourceal, crush the ligament teres, and cause foveal impingement. So that's the distance between the top of the fovea to the medial sourceal. For 10 degrees is healthy. That means the fovea will not come in contact even with the adduction of the hip. That's the total head cartilage. I showed that as normal just to show you this example where called caput valgum. The head is in valgus, right? Most of the healthy head is outside the sternum. The fovea is against the sourceal. So if you look at the healthy head, that's outside, right? A lot. That's the true contact with the healthy cartilage on both sides. And the fovea is touching half the sourceal, called foveal impingement. So just one word on CT scan. I don't get CT scans in general, but 3D reconstruction CT is the best to show the cam morphology. If you're starting off in the beginning and want to know if there's cam or not, where the cam is, you can get a 3D reconstruction. That's the best image for cam morphology. There are a lot of advantages of CT in other ways also, but as you get experience, you don't really need a CT because the radiation is significant in our hospital. See the CT, you can see the cam like this before and this after. It's a nice tool in the beginning to understand. And CT can allow you to even do dynamic things. This is a video, but I won't go through it right now for lack of time. And MRI for me is to more not diagnose impingement, but to not impingement, but to rule out other pathology. In India, it's very, very common to see AVN and bone marrow edema syndrome associated with impingement. I'm very confident clinically that they're impinging, but you get an MRI and usually they have some AVN or not usually, but a lot of them have AVN and bone marrow edema. That means that your impingement is not the primary cause of pain and you should not treat impingement till these are resolved, AVN and bone marrow edema syndrome. The MRI can show labral hypertrophy, labral tears, labral cysts. An MR arthrogram and 3T MRI can show labral tears. Plain MRI misses a lot of labral tears. You need distraction actually to see an articular flap. So even there's a full thickness articular flap detached from the sternum, you won't see it on a regular MRI. And it's hard to get distraction because you need 60 to 70 pounds of pull on the hip to do a distraction MRI. So a beautiful MRI can look, you can see all these things, like it's beautiful, you can see every little bit of anatomy, but all these are not important because you can predict all this on plain X-rays with some experience. And for me, MRI is to rule out other pathology. That's where I'm going to stop.
Thank you very much. So that was really a lot of additional things we have to look forward into X-ray. Dr. Asim, I think we were mesmerized seeing all those little inputs on the femoral head.
It's explosion of knowledge, too much to absorb. So we talk again and again and again.
So we'll have to refer this to again.
OrthoTV has a recording. So
yes. So we have to see again. Harshwardhan, your opinion, do you see all this on X-rays? As
I'll be very frank, sir. I don't see all this on X-rays.
You don't
Most often we don't get X-rays to read. We get a MRI requisition. But Dr. Prasad sir told that the role of MRI is not that much in diagnosing, but to rule out other pathologies. So we'll be discussing that now, like how MRI can help in FAI.
Right. Okay. So any other question to Dr. Prasad? Alok, you have any questions?
I was just thinking that those patients who come in our OPD, mostly maybe the incidence of AVN is higher on our side. So after the initial X-rays, if we are not coming up to a diagnosis, we get an MRI done. And patients do show up these signs of AVN, but in those cases, should we look also for the impingement signs?
So
Did you ask me a question?
So yeah, his question is, a lot of these patients who have who come clinically with early AVN signs. So should we look for signs of impingement as well?
No. When you have diagnosis like a pathology, like a tumor, infection, bone marrow edema, or AVN, that you should treat or take care of first. Because impingement is it's a older problem, chronically there. It may not be the cause of the symptoms. So don't treat the impingement till you resolve the primary thing you found on MRI.
Okay.
It's only when the MRI is negative and you look for a diagnosis, all these are important.
Correct. My question is like, how do you differentiate between the head valgus and the neck valgus on radiology?
Which one again? Which valgus?
Head valgus and neck valgus. Yeah.
Right. So when you draw your lines or even eyeball it, the deformity between the shaft and the neck will be your neck shaft coxa valga. And if the neck axis to the head should be nice and perpendicular on the neck. The head should be placed at a right angle to the neck axis. If tilted into valgus, that's head valgus.
Okay.
If that's tilted into varus, that's head varus, more commonly seen in a slip.
Okay.
Okay.
Dr. Ishant wants to know, what are these clicks in the hip? There are so many persons and young children who come with clicks in the hip.
Clicks in the hip in newborns are usually from, we think it's dysplasia, right? When you think about click in the newborn person, we think it's dysplasia. In a younger, not old, in a child, like an older child or an adolescent, clicks are usually from impingement or benign. The soft tissue is moving on the bony prominences.
Okay. Fine. So after absorbing a lot of this knowledge, let us see what radiologist perspectives are there on FAI. So Harsh, can you share your screen, please?
Sure.
So don't worry, Harsh, this recording would begin. The OrthoTV intermittently, just this sound comes.
Is my screen visible?
Yes, your screen is visible.
Yeah. You can make it come.
Yeah. A very good evening, everyone. First of all, I would like to thank viewers and Dr. RM Chandak sir for giving me this opportunity on short discussion. It was a wonderful discussion on X-rays, a very detailed one. After that, hardly anything is left for MRI to tell. But what we'll be doing is we'll be discussing few interesting cases and just a short PPT on role of MRI in FAI. So this is a 34-year-old marathon runner who has come with a left hip and groin pain since last 3 to 4 months. The lab parameters are absolutely normal. There is no history of steroid intake. So going through our MRI images, this is the axial oblique fat suppressed, the coronal fat suppressed, the SACH T2 and the coronal T2 images. So the obvious finding what we can see here is the presence of bone marrow edema in the proximal femur. So this is the most obvious thing which sticks to us, that there is a bone marrow edema. So once we see this, what are the things which we consider in a marathon runner? Is there a stress or a insufficiency fracture? Is it a transient osteoporosis? Is it a early AVN or something else? So now coming to the next finding, what we are picking up on MRI is this hypointense line, what we are seeing close to the anterior aspect of the head. So this is the subchondral, the stress or a insufficiency fracture, which has led to this edema. Now, what could be the cause for fracture in this young patient who is otherwise absolutely normal? Vitamin D, calcium levels are normal, no history of trauma, and a regular marathon runner. So another interesting finding what we are seeing is this classic bump on the femoral head. So this is a typical case of a CAM FAI where we are seeing this bony bump, and along with that, as soon as we see this, we need to look for the anterior labral tear, which we do see here. So this is the anterior labral tear. Again, the coronal images will be we can see this tear very well on this image. So now with this finding of bone marrow edema, insufficiency fracture, a CAM pattern of FAI and the anterior labral tear. My genuine doubt to Dr. Prasad sir would be, can this insufficiency fracture be attributed to this CAM FAI, or is this just an incidental finding? Patient has pain since last 3 to 4 months, and if this patient is if he again goes to marathon after 12 months, so is there a chance for a repeated fracture because of this CAM morphology?
You want me to answer now?
Yeah, sure.
Yeah. So CAM morphology is there for sure, but CAM impingement is clinical exam, like I said, is a clinical diagnosis. Your labral tear being there is very supportive of CAM impingement. Right, so very likely that the labral tear was caused by the CAM bump. But I don't think the bone marrow edema syndrome has anything to do with impingement. And the subchondral fracture, I read about bone marrow edema syndrome more after coming to India. It's a very rare diagnosis for me in America. But here, almost every month when I see a FAI patient, when I get an MRI, probably 2 or 3 have bone marrow edema or AVN. So this is probably a process where the bone marrow edema syndrome is causing him the subchondral fracture. I learned that subchondral fractures are not uncommon in bone marrow edema syndrome and in pregnant ladies, and go on to collapses also. So that's something new I learned after coming to India.
Okay. So probably it's just a coincidental finding that we are having a CAM and an anterior labral tear. The fracture and edema is a separate entity which is going on.
Yes. The CAM has been going on for a long time. It's probably not symptomatic enough for him to seek treatment. This bone marrow edema syndrome is what brought him to the doctor.
Oh. Thank you. So moving on to our next case.
So hold on, Harsh.
Yeah.
I would like to ask Prasad sir. Sir, I was suspecting different pathologies in this case.
Yeah, two separate pathologies. I don't think they're interrelated.
So what my understanding was before discussing with the sir, that probably this CAM morphology has resulted in a kind of an insufficiency fracture because of a routine marathon runner who is otherwise healthy. A bony bump might have caused some kind of an impaction injury or a fracture which has resulted in edema. But now probably we can think that both the processes are separate.
Harsh, seeing this image,
Yeah.
I got interested in the upper arsenal which you have to read the images. So there are
Okay. So this is
the upper one.
Yeah. So these are our packs and the angle measurement and various tools which we have to study the MRI.
Okay, fine. Thank you. Can you go on to next case, please?
Yeah, next case.
How do you proceed in this case, sir? a question to Chandak sir. Like now we have a insufficiency fracture, we have a cam lesion, we have a bone marrow edema. Now, as a clinician, how do we proceed?
Yeah.
Shall I answer that?
Yeah.
Yeah. So for me, bone marrow edema syndrome is the idiopathic hyperemia in the femoral head, a lot of effusion. I don't know exactly why it happens. So I treat them with bisphosphonates now, oral bisphosphonate, never injection, oral bisphosphonate for 2 or 3 months to settle it down and prevent collapse from happening. Once the bone marrow edema syndrome goes away, they come back and my exam still shows they have pain and they still have pain and my exam shows they have impingement, then I'll offer treatment. But the bone marrow edema syndrome has to resolve completely because that can lead to collapse and I don't want to intervene if the collapse is going to happen. So I want to make sure that the edema syndrome, the bone marrow edema is gone completely on a repeat MRI, re-examine the patient. And if he still has pain and cam impingement, then he'll get a correction of the impingement.
Alok, do you put them on non-weight bearing strategy?
It should be preferred because he is having a subchondral fracture as well. I mean, I would prefer a 6 weeks non-weight bearing strategy for him.
Yeah. So
I just have one observation in India. I could not get anybody to be non-weight bearing. Either it's bed rest completely or they don't come with any crutches or walker. So my avian patients don't follow my advice at all when I say non-weight bearing.
Yes.
Non-weight bearing is impractical, Chandak sir.
Yeah.
Activity modification is probably the right word, that you reduce your activity to bare minimum, what is necessary. Yeah.
Agree. Yeah.
Prasad, may I ask you why you are so much against injectable bisphosphonate? They are far more effective.
Where did you learn about
delivery is confirmed. Here, don't take
you,
medicines.
Let me ask you this first. Where did you learn about injectable bisphosphonate?
Zoledronic acid, because we prescribe the medicine, but they don't take it.
No, but where did you hear about injecting bisphosphonate in the femoral head?
No, not injecting in the femoral head. IV should.
Oh, so you can definitely give it IV, one shot. But I think
that assures the delivery of the medicine.
Right. See, the vascularity is already. Oh, okay. Anyway, you can give IV.
Yeah.
I'm talking about injecting into the head. I inject
not injecting.
Inject into the head.
Not injecting.
Here, with such edema, there's no point in trying to inject. In AVN into the center of the lesion, it's very good option. But I don't think it's a good option here. But yeah, systemic bisphosphonate, oral or
systemic.
IV.
Okay. So I think Harsh, it's time for you to move to the next case.
Yeah. The next case visible on screen or
yes.
The same?
Yeah, we can see.
Yeah. So this is a 42-year-old female who has a long-standing right hip pain, especially when she sits crossed leg. So there is a very typical history here. Now coming to our images, all 4 are fat suppressed sequences: the coronal, axial, and sagittal, and this is the left hip. So unlike the previous case, we are not seeing any obvious bone marrow edema in this. The femoral head looks grossly okay. But what's happening here? There is a definite evidence of a over coverage, and which we confirm on our axial images. The posterior part of the acetabulum is kind of impinging or hitting on the posterior aspect of the femoral head. So resultant changes, we can see there is a posterior labral tear here, posterior superior labral tear with a very small paralabral cyst. And on our sagittal images, this is the posterior superior labral tear at around 2 o'clock position. So although there is not much of edema, but there is a definite posterior superior labral tear and impingement on this, and probably this is responsible for the patient's symptoms, the pincer pattern of cam.
Okay. Any opinion from Dr. Prasad on this?
Totally agree. Yes, totally agree that it's posteriorly impinging and that damage is, yeah, definitely. I agree with the diagnosis completely. Your assessment is right on.
The impingement might have caused the tear of the labrum.
Pardon?
The impingement might have caused the tear in the labrum.
Yes. Labral tear is almost always from either dysplasia or impingement. It's not just from old age, in my experience. It's always mechanical. So labral tear should never be a diagnosis.
Okay.
So all labral tears are not symptomatic and all of them do not require treatment.
Correct.
Fine, Harsh. Please go ahead.
Yeah. So after going through these two cases, let us look at few theoretical points. Are these slides visible?
Yes, we can see them.
Yeah. So regarding the MRI in cases of suspected FAI, it's very important that we don't ask for a routine MRI hip, because if we do a routine MRI hip, we'll be missing out on FAIs, labral tears and cartilage injury. So there has been various sequences, various planning of MRI which has been suggested to diagnose FAI. Now to understand this concept, why we need a separate planning in cases of FAI. The hip is a spherical structure. Let us assume this as an cut orange. So there is a peel here which is acetabulum and the acetabular labrum. The pith here, which is the femoral cartilage, and the pulp of the orange, which is the femoral head. Now, what happens in our conventional imaging when we are planning this MRI in coronal sagittal planes? We won't get the equal or a symmetrical distribution of the femoral head, and we will be missing out on labral tears or a cartilage injury along the anterosuperior or a posterior-superior aspect. So it's very important that we plan our MRI separately, which is starting from the center of the hip, so that we get these kind of equidistant images. So this is what happens in a routine MR, where we don't plan from the center. These are the axial and coronal images we get, and what happens in radial imaging, which we plan from the center, is a nice visualization of the labrum and the hip joint cartilage. So there is a different planning, different protocol in cases of femoroacetabular impingement. Now all these angles has been described very well by the sir, so I won't be going into details, but what commonly we use in cases of CAM on MRI is the alpha angle and the anterior head neck offset ratio. Again, we prefer this on an oblique axial or a radial image, where alpha angle more than 60 to 65 is pathological and anterior head neck offset ratio less than 6 to 7 mm is significant. In cases of pincer pattern of FAI, the lateral center edge angle, which has again been described in the previous lecture. I was talking about the labral tear in one of the case. So this is just like shoulder. We try to classify the labral tear clockwise on the end-on view of the femoral head, whether the tear is anterosuperior, posterior-superior, posterior-inferior or antero-inferior. So just coming to this is from one of the article which is almost 6-7 years old. So what are the facts, fictions and the fantasy regarding FAI? FAI syndrome exists as a distinct syndrome. We all know that it's a fact now. Impingement between femur and acetabulum is abnormal. Now this is fiction. As sir told, there can be a normal there can be a normal impingement also. Treating FAIs relieves the symptoms. It's a well-known fact now. Now, this is the important point here. FAI morphology and FAI syndrome or impingement is a different thing. We might get on MRI, we get FAI morphology in every 4th or 5th hip case, but they do not have impingement. So all FAI morphology don't lead to FAI syndrome or impingement. Now, the acetabular labral tears occur in FAI. It's a well-known fact, but all labral tears are not due to FAI. It's a fiction. There can be other causes of labral tear also, like a trauma. FAI morphology is a risk for osteoarthritis. 7 years back it was unknown, but now it's a well-known fact that it's a risk for osteoarthritis. But all FAI don't lead to osteoarthritis. And treatment of FAI delays or prevents premature hip osteoarthritis. This I think sir will be a better person to answer. So since the topic was about the impingement, other than this FAI, there are few other impingements in the hip which we can diagnose on MR. Like this is a case where we are seeing edema along the iliopsoas tendon. So this was a case of a iliopsoas impingement. Another commonly missed impingement is the ischiofemoral impingement, in which the patient has the typical pain in flexion, abduction and external rotation, and many times it radiates to the knee. So what happens in this? This is a normal ischiofemoral interspace that is between the lesser trochanter and the ischial tuberosity, which is usually more than 8 to 9 mm. Now, when this space gets reduced, there is a compression and impingement on the quadratus femoris muscle, which can result in the edema. So this is a ischiofemoral impingement. So, take-home points regarding MRI in FAI. Clinical history, examination findings are the most important thing before we start a MRI. If the MRI is for FAI, we need a different planning and sequences. But along with that, we need to do our routine hip MRI also, because labral tears at 9 o'clock, 12 o'clock, 3 o'clock and 6 o'clock will be seen on our routine MRI. The role of MRI includes the characterization of the FAI. Are there any signs of active impingement on MRI, which may include cystic changes, edema at the head neck junction, classifying the labral tears, the cartilage and the arthritis status, associated findings, and the most important is excluding the other pathologies. Thank you.
Thank you so much,
Thank
Harsh.
Sir, I have a question for Harsh.
Yeah, please go
Yes,
ahead.
sir.
Since you recommended not to have a normal MRI pelvis lesions, what exactly do you expect from us? What should we be writing there?
Sir, requisition should have there is a suspicion for FAI or an impingement test is positive. So then, if that much history is given, we'll plan our MRI accordingly.
But Harsh, then we will be very specific in our diagnosis that it is FAI.
Yeah.
And there are a number of reasons for hip pain. So,
Yeah.
won't it be like?
Yeah, suppose, sir, on clinical examination, the impingement test is positive. If we write FAI, so it's not that we won't be doing a routine MRI hip. As I told, routine sequences cannot be replaced. We need to do add-on 2-3 sequences so that we get a good visualization of labrum and cartilage. Yeah, we won't be missing AVN on that, even if we are writing that suspecting.
So, Chandak ji, may I ask one question?
Yeah,
Chandak
Gadigoni
ji.
sir, go ahead. Gadigoni sir, go ahead.
Sir, I want to ask the Jain Harshwardhan, which Tesla machine can give a very perfect image like this? Because most of the majority center, they use 1.5 Tesla machine. So we don't get a very proper image of this very finer details of the hip impingement and other things. So what you advocate when we prescribe to a patient that from this center you should get the image?
So, preferably, sir, as we all know, 3 Tesla should be preferred. It will have a very good spatial resolution. But by telling this, I am not telling that 1.5 Tesla will be missing on diagnosis. Only thing is, we need to give at least 30 to 45 minutes to do that MRI. If we take out the patient in 15 minutes by doing routine sequences and not thin sequences, we are going to miss out. So a 1.5 Tesla MRI can also be sufficient to diagnose all this, but the resolution of labrum and cartilage will obviously better on 3 Tesla MRI.
Very diplomatic.
I just want to show a couple of MRI pictures here.
Yeah.
You see this here, the defect here.
Yeah.
Here the divot. These are signs of impingement on MRI. And one more.
These are all arthrogram images, I guess.
Maybe, but these you don't take the arthrogram for this. It's the outline of the head.
Yeah, but the images.
They can be. They're not mine. They're from. I copied from. Here's the divot, corresponding divot arthroscopically. And I want to show one more little picture. This is not classic. Not classic means it's not common. A lot of people with impingement cyst on X-ray do not show a cyst on MRI, but this is an impingement cyst. See the bump, and right underneath is the cyst. All right.
So this is what I'm going to look forward in future X-rays of pelvis, whether in that area I see a cyst, and I go back to my memories, and there were certain X-rays where we used to find some lucencies in those corners. So I don't know whether we missed FAI in those. My question to you, Prasad, was FAI a diagnosis only after imaging came into being, or was it there before the imaging also?
FAI was a clinical diagnosis. I'll introduce an FAI to you in a minute. Let me see. I have some problem with my PowerPoint. Unshare, stop share. I'm looking for my primary talk. FAI. Let's see that.
Yeah, Dr. Asim Negi wants to ask a
Yeah,
question.
Prasad, that presence of a cyst in the anterior-superior quadrant, can it be the cause for?
Look for my FAI.
So let him be comfortable. He's searching for his talk.
Yeah.
Yeah, no problem. Feel comfortable. You'll be able to search it. No problem.
All right, I'll find it. So give me a minute.
Yeah, no problem. By that time, we'll continue our discussion with Harsh.
Yeah,
Harsh?
just want to add on one point, sir, regarding that cyst. So
Yeah.
practically when we do MR, the presence of small cyst and adjoining edema at the anterior head neck junction, it's
you
a
see
very
my,
good
slide
indication
now?
that there is a impingement or active impingement going on. If the
Do you see my talk?
No, not able to see. Prasad, we can see
Hello?
your video. Yeah, we are not able to see your talk. Harsh, how commonly, how much time it takes to for a bone marrow edema to disappear? Have you have successive MRIs?
Yeah. So we have followed few patients, sir. We did a MR at 6 weeks where the where the edema reduced, but still it was persisting. Even at 9 to 10, even at after 9 to 10 weeks, it was persisting. It almost took 5 to 6 months for edema to completely go off from MRI.
Okay, so that
Yeah.
is regarding the hip bone marrow edema, and
Yeah.
same at knee also.
Knee, sir, we have not followed these cases of song and all. We don't get
I can't hear anybody.
Yeah, Prasad, can you delink again and join back again?
Chandak, I can't hear anybody.
So are you muted?
No, he's not muted. You're not able to share the screen as well, or he's not able to hear us?
Now we can see your screen. Prasad, we can see your screen now.
Chandak?
Yeah, we can see your screen now. You're audible.
I think our voice is not.
Our voice is not going to him, no?
He's not able to listen.
Prasad, can you listen us?
No, sir, I think.
I think I'll call him and ask him to join back again.
Hello? I can't hear. I can't hear anybody. Okay, shall I continue the talk then? I don't know how to answer the question. Okay, all right. All right. So the next topic will be femoral impingement. It's a long talk. You can stop me at any point.
Yeah.
So the first question is, are we missing FAI in the OPD? Probably, because the clinical diagnosis, there's no definitive radiographic features to diagnose. Not like a slip that if you miss it, the next guy is going to diagnose it. And also the presentation is very variable. I'm going to show you how they present. It's not a disaster to miss. It's not like you missed a tumor, AVN, or something else, right? It's a slow process. So it's very common that we miss it. Though even if you miss it, in India, what I notice is there's less arthritis.
Yes.
So it's not a big deal. The history of FAI. I think the modern concept of impingement came from Reinhold Gahn. He did periacetabral osteotomies for his dysplasia and ended up overcovering a lot of people. And in 5 cases, he opened up the hip and found that by overcovering the acetabulum, the osteotomy, it caused impingement. Then he called it osseous stop to motion, a bony block to motion. Then he said coxofemoral conflict are the different names he gave. So for us to understand, by the way, let me give a disclaimer. I'm not going to quote a lot of papers, and you may argue with me with recent literature, but I've been doing FAI since 1998. So a lot of stuff I'm saying is more from experience and a few publications I made myself. So the definition of FAI to encompass all possibilities, all types of FAI. The motion-induced pain and damage from morphological abnormalities of the proximal femur, acetabulum, or both. So bony variation causing pain with movements of the hip. Dysplasia, in comparison, causes static damage. You stand and you get pain from dysplasia. You don't need to move. So it's a mechanism of hip pain from normal movement to abnormal bone. So to give a little understanding, the endpoint for hip motion, right? The endpoint for hip motion is either soft tissue restraint or bony constraint, right? So you're going to flex. You flex till the neck hits the sternum in the front, or the back structures won't stretch anymore. And test on yourself now or any time. Hip flexion is more if you keep the hip in adduction. That means you're bringing the neck perpendicular to the sternum, then you can adduct a lot more. So when you try to adduct and flex, you feel the stress more, mostly in the butt muscles in the back, because what you did is you decrease the risk of impingement in the front. When you do it in abduction, the flexion abduction, the neck is coming closer to the sternum, and you won't have as much flexion. And the end point will be a bony block at the front in the groin, not a stretch in the back. Right? The impingement is a pathological bony constraint, not from soft tissue tightening. The bony constraint during functional range of motion for that hip in that patient. So not everybody needs the same range of motion. Maybe the right and left hip don't need the same motion. So it has to be within functional range. You're impinging 100 times a day. You may not notice, but most common cause of dislocation of a total hip is impingement. Malaligned cup, neck, whatever, right? Impingement is the most common reason why total hip dislocate. And there are cases of recurrent hip dislocation, traumatic hip dislocations recurrent from impingement. And I personally believe that most traumatic dislocations have actually impingement to start with. They traumatically impinge in the front and lever out from the back. I'll show you some examples. Here's a total hip. On the left side, cup is anteverted adequately. Right side, no anteversion. And this right hip dislocated every time you flex to 90 degrees because the neck will hit against the rim of the sternum and lever out the head to the back. Here's a traumatic dislocation. One of my patients, young adult. Look at the cam morphology. You don't know if they're impinging or not because you don't do an exam before they had the trauma, but you have risk factors for impingement. Here's a different patient, posterior dislocation. I'm doing arthroscopy. There's labral tear in the front. Look at this divot. I didn't create this. This is from trauma. The anterior acetabular rim dug into the neck here and levered the head out from the back. So I debrided and did osteoplasty to relieve the impingement, to prevent recurrence of instability or discomfort. So what is significant, clinical significance of FAI? It's rather common. It's easy to diagnose clinically. After this talk, you'll be comfortable diagnosing FAI clinically. It's not difficult to treat. You don't need to know arthroscopy to treat FAI. FAI can be treated with open operation. Last question was, is there a role for open surgery? Absolutely. You can do almost everything I do arthroscopically by open methods very comfortably and easily. And the outcomes are quite good. You select the patients correctly before they have too much damage, the outcomes are good. And though Dr. Jain said that we don't know if it's caused arthritis, yeah, treatment prevents early arthritis because there's a lot of damage that happens in young people. If you leave it, I think they'll get arthritis. You don't have a 20 or 30-year long-term studies to tell you how often, but we see enough damage to say that it causes arthritis. So a few different types. Dr. Jain introduced you to one. There are two others. Extra-articular impingement. AIIS, I mentioned already. Greater trochanter can impinge all around and lesser trochanter against the ischium. I'll show you an example. So intra-articular, you have cam. Cam is always from the femur, an spherical femoral head. Pincer, a lot of people think it's a sternum, but pincer can be from femur or the sternum. Skeppy, again, always from femur. And FII-induced instability is something I'm going to introduce to you minimally. And then I'll show you foveal impingement example. So here's the patient. AII is prominent. When the hip flexes up, the neck and the prominent AIIs and squeeze the rectus and the capsule and everything in the front and cause pain. That's called AIIS impingement or subspine impingement. Right? A different example where it's very prominent and you can dig into the soft tissues in flexion. Not the same patient, but you can see how avulsion fracture caused ossification into the rectus that can impinge. Here's a typical Perthes patient. High trochanter, crux of breva. This GT can impinge all around. Internal rotation, external rotation, abduction. All can be restricted with the high riding GT. Here's a case example from Pune. I don't have a preoperative X-ray, but his X-ray was near normal. I didn't really see anything. But when I examine him, look at the video. And he's in lateral position on the operating table. That's the internal rotation flexion, about 15-20 degrees. But external rotation would be 60. And he has about 25-30 degrees at the most. And he has pain right there in the back of the buttock. So very thin patient with a great trochanter. The trochanter is impinging on the back of the ischium. We opened him up, did a trochanteric decompression. So SSD approach and took most of the trochanter off from the back. And look at how much external rotation we got. And that GT can even pinch the sciatic nerve in the back. This is my example of LT impingement. It is an osteochondroma or an avulsion fracture that healed with a bigger callus. Quadrate femoris is being compressed. This is not pathognomonic, and even the distances are not pathognomonic. Against a clinical diagnosis. And the way to test it is in adduction, not abduction, adduction, and flexion and extension. And then when the pain is relieved with the internal rotation and aggravated with external rotation, then that's subspine impingement. Ischiofemoral impingement. The treatment is either you do ischioplasty or lesser trochanteric excision or a transfer. Increase the space. Here's a textbook slide where they're showing the sciatic nerve being impinged between the lesser trochanter and the ischium. I don't think that happens because the quadratus will push the sciatic nerve, right? It won't go between the ischium, but the greater trochanter can impinge against the sciatic nerve. I've seen cases. Intraarticular. It can be anterior, in flexion and internal rotation. Lateral, in abduction external rotation. Posterior, in extension external rotation. The posterior FIA is the example that the Jain showed in the second case. Based on the damage in the hip, CAM type, always femoral deformity, asphericity. Pincer, usually from the acetabular side, but can be from the femur. I'll show you an example. Counter coup is front impingement causing posterior damage. And scathy is different. We had a little presentation and I'll show you an example. Foveal impingement. So CAM damage in a spherical femoral head causing stress on the acetabular cartilage, separating the cartilage from the labrum and from the acetabular bone. See the sphericity, squeeze itself in, and then damages its cartilage. And the labrum gets separated. Here's a little video. See the CAM bump, squeezing itself in, causing damage. So my patients are pretty young, teenagers, 12, 13, 14, even younger sometimes. So this looks very healthy. Labrum looks really healthy. A little fibrillation there, not entirely normal, but when I poke it with a probe, I'm actually going in this gap all the way down to the bone. That means that the cartilage, the acetabular cartilage and the labrum are separated. It's called contralabral separation, the earliest damage from CAM impingement. Another example, the labrum looks really healthy. The probe, half of the probe is inside the tear. That's a labral tear. Softening like this is very, very common in CAM impingement. A little more damage than the previous cases. Here, the full thickness flap is coming out. Okay. Here's another flap from CAM impingement. Again, big flap. So when the flap happens, that hip is going to get arthritis at some point. Another example of damage. So this is what's causing it. It's arthroscopic view of the femoral head. There's a bump on the head right here. Some cartilage damage on the CAM bump from there against the acetabular. Again, this is how the femoral head can be worn against the labrum on the CAM bump. Do you appreciate the CAM bump here? Big bump. The head neck junction should be stopping right here. There will be concavity going down. That's CAM bump. Another big CAM. It should be curving down into concavity. And this CAM bump is covered by articular cartilage. So smooth on smooth impingement. Again, see this red where the labrum is impinging on the head neck junction and this CAM is extending beyond the head neck junction all the way till here. Again, osteoplasty started, and this is the cam bump. All this cartilage has to be removed. An open example before a new arthroscopy. This looks almost like an osteophyte, but her cartilage is reasonably healthy. So cam osteoplasty with open technique can be done with SSD or through a mini open approach. Again, cam arthroscopic before and after. This is the only example I have of a recurrent cam after my own osteoplasty. We developed a new bone, another cam, so I had to dissect it a second time. Pincer, on the other hand, is damage of the labrum from being crushed between the acetabulum and the femoral neck. So you see sclerosis, grooves, calcification, right? Not as much acetabular damage. See the pincer labrum between the neck and the acetabulum. This impingement in the front is causing counter-coup damage in the back. The labrum is not nice and healthy. It's rounded. Early sign of pincer impingement. Here's the rim of the acetabulum causing a wear and tear on the femoral head. Labrum is crushed here. That's a classic pincer impingement. Very damaged labrum from pincer impingement. This is pincer here and cam here. The mixed, most tips have both. This is a little divot. This is the head, neck. The pincer impingement is causing a divot in the head. All this wear and tear on the femoral head by the labrum. So the treatment for pincer impingement is you remove some rim of the acetabulum, repair the labrum back, and then osteoplasty of the head neck junction to make it nice and round. This patient has open growth plates, so the osteoplasty went medial because the cam was epiphyseal from the head of the femur. This is one of my recurrent impingement. I did previous repair, not enough, so I went back to remove more, repaired the labrum again, and did cam osteoplasty. Here's a rare example, not a rare, but an example of femoral side causing pincer impingement. So not all pincer is from acetabulum. This is femoral side, skeppy, slipped epiphysis. Didn't remodel adequately, and the bump is squeezing the labrum. The skeppy, the impinging structure is not smooth cartilage, it's femoral neck. Right? This femoral neck is pinching and abrading the articular cartilage. So in a really young, early skeppy, that's the scraping of the cartilage, little more advanced damage. And they can have intense synovitis from a skeppy. This is all synovial hypertrophy. So in idiopathic cam, it's a round, spherical head with a bump that's covered with articular cartilage. In a skeppy, it's the neck bone. It's smooth on smooth with softening of the cartilage. Here it's abraded and pinched. It's full thickness flap here. It's all abrasion here. So they're different. Again, this is covered with articular cartilage, and this is raw bone getting fragmented against the acetabular rim from impingement. The osteoplasty for idiopathic cam is always medial to the physis to get into the head. Here, I don't need to go medial to the physis. I was just looking at where the physis is. I can stop at the physis. So skeppy has posterior tilt, cam has anterior extension. Skeppy has a bump from the neck bone. In cam, it's epiphyseal cartilage bump. In a skeppy, it's pincer and abrasion. While in a cam, it's carpet phenomena, the soft cartilage. And the osteoplasty is to the physis in a skeppy, and it's medial to the physis in a cam. I tried to publish this, haven't gotten it approved, accepted yet. But this is I have a case series of skeppy becoming idiopathic cam. This is an example where the slipped epiphysis. We did an osteotomy of the neck and got this corrected. He did well for a couple of years. Then came back with new bone, a new cam. That's not just the heterotopic bone. This is cam of the head, filled in all the way. So when I went in, this was covered with articular cartilage. We grew new articular cartilage on this bump. So we did arthroscopic osteoplasty, rounded it off. So cam developed after skipping. Then another example of damage is FAI-induced instability. Impingement in the front, instability in the back. Like I said, most traumatic dislocation happened from that. Not from chronic impingement, an acute episode of impingement in the front, hyperflexion, and then the femur impinges against the acetabular rim and dislocates the head backward. If there's no major trauma, the anterior impingement can cause subtle instability and cause either hinged abduction, right, trochanter impinging on the side, or contra damage in the back. I'll show you an example, or traumatic hip dislocation, like I mentioned before. Again, anterior impingement, posterior damage, that's contra. They can get a cyst on the head. He's a scaphy patient, impinging in the front, but look at the osteophyte in the back. How can you explain that? Because he has all this contra damage in the posterior acetabular. Cartilage completely gone in the back of the acetabular from anterior impingement. Here's the patient who doesn't have much deformity. A small cam in the front, open surgery at that time. There is cam for sure, but small cam. But what he did was, he was getting contra damage on the head in the back. This is the head getting damaged in the back from anterior impingement. Now, examples of foveal impingement. Fovea is not a weight-bearing area, so the fovea has to bear weight. That means it's going to pressure the ligament teres. It's crushing in between the acetabular and the fovea. That causes pain and dysfunction. In that example I showed you, fovea alta. The fovea is very high. That's healthy cartilage contact. That's the ligament teres that's getting crushed between the fovea and the acetabular. They can have crushed ligament teres like this. And the treatment for this was varus, but because this patient has coxa vara, we needed to transfer the trochanter disc called relative neck lengthening first, and then do a varus osteotomy. So RNL plus varus osteotomy is the treatment. Now the fovea is below the source seal, down here, not impinging anymore. Here is the reverse source seal patient I showed you earlier. Here the ligament is getting crushed between the acetabular wall and the femoral head. Medial osteoarthritis. Negative source seal angle. See the primary compression trabecular line is going medial to the source seal to the acetabular fossa. Medial osteoarthritis. You can get a medial osteophyte like this, not the same patient, different example of medial osteoarthritis. So a few rare forms of impingement. Psoas impingement, it's not that rare, but it's more common with the total hip patients with the cup that's exposed in the front, right? Psoas tendon. And then there's a rare, but I don't believe in it, type of, okay, here's the example of psoas impingement. Psoas on the top, labrum is a little crushed. People think it's psoas impingement. I don't believe it's the psoas that caused this. There's a cam that did it, but this is an example given in the book for psoas impingement. And people say that this is a capsular thickening called zona orbicularis. This is a ligament on the head, at the bottom, and on the neck. And these can impinge, called zona impingement. Just one slide on etiology of cam impingement. Cam morphology is very common in animals that run a lot. So kids who jump and run a lot during growing age will get cam morphology, like a horse step. People who squat, like my generation, we grew up squatting and sitting cross-legged in a younger age. So we don't get cam morphology because the heads are nicely molded by the acetabular. So we get more of a monkey hip, right? The contortionists have narrow necks. So clinical diagnosis, right? Symptoms. What are the symptoms people come with FAI? Hip pain, not always. Groin pain is classic, but at the same time, probably 50% come with groin pain. A lot of people come with thigh pain. A lot of people come with knee pain. It's your job to check the hip when they come with knee pain. And the pain is more with sitting and flexion. A seats in a car will make the hip worse because they have to flex more. Like a sports car is worse than an SUV. And then they can get pain with running. The damage happens with sitting, but the pain happens when they're running because the labrum is irritated and torn already. Clicking is not an uncommon complaint. Chronic stiffness, they'll say they're never very flexible as a child, is a common complaint. And then there's the association. We diagnose a lot of people with hip impingement when they come with low back pain, SI joint pain, muscle strains, and osteitis pubis, and sports hernia, abdominal strain for the muscle, the abdominal muscle. All those are presentations of FAI. Unless you know all these, you're not going to make a diagnosis of FAI. So you'll never know if you missed it or not, unless the next guy is going to make the diagnosis for you. Avulsion fracture, almost always from FAI. So what are the signs? What are the signs of impingement? Flexion, adduction, internal rotation, or pardon, or called impingement sign. This is a test for anterior impingement of the hip. But keep in mind that this test is positive in every hip pathology. Arthritis, synovitis, every hip that has any pathology in the hip is a sign of hip pathology, but not specific for impingement. So it's called impingement sign. It becomes very important when you take the range of motion into consideration. So you have flexion, adduction, internal rotation, pain, and the flexion internal rotation is restricted. So when you flex to 90 degrees and internal rotate, and there's only, say, 0 or 5 or 10 degrees, normal is 20 to 30, then it becomes more important. Decreased motion with pain and flexion, adduction, internal rotation, and no pain in other direction has to be impingement, right? That's as specific as it can get. It's very sensitive, not specific at all, the pain, but becomes very specific when the range is restricted and there's no pain in other direction. That's not the only way impingement happens, but that's impingement for sure. If somebody has 0 degrees of internal rotation, 90 degrees of flexion, and that's painful, there's a clear bony block in the groin area, and no pain on external rotation, that's impingement. Whatever the cause is, Corti, Skefi, whatever it is, it's still impingement. That's how you diagnose impingement. But there's a lot of people who don't have pain and still impinging. We're going to miss a few, but you're definitely going to positively diagnose impingement with this combination. Then flexion, abduction, external rotation pain is from lateral impingement. Straight flexion pain is more commonly from subspine impingement or AIIS impingement. Extension, external rotation stress, right, can be post impingement or can be anterior apprehension. You impinge in the back, you'll be unstable in the front. So these 5 tests are very routine for me. I do them every time, and I can pick up a lot of information just on these 5. Flexion, adduction, internal rotation, that's impingement sign. But when this range is decreased, that's impingement. And when you press this and you have posterior pain, that's posterior apprehension. This is extension, adduction, and external rotation. It causes posterior pain, that's posterior impingement. It causes anterior pain, that's anterior apprehension from instability. So 2 tests with a lot of information. The workup, we talked about X-ray, how it's important for me to get a pelvis AP. Any frog lateral will show you the head neck junction, different parts of the head neck junction of the femur. So you get the one that shows you the area of interest. So if I want to look at the superior head neck junction, more like anterolateral, I get a done view, less flexion. If I want mid-anterior, it's a frog, right? CT scan is great. MRI is more to rule out other pathology like we talked about. You need an MR arthrogram to really rule out a labral tear or diagnose a labral tear. But labral tear is not really a diagnosis, just a finding I expect to see intraoperatively and take care of. If you're in doubt where the pain is coming from, do an injection to the hip, lidocaine or novocaine, local anesthetic injection. So a summary slide. Morphological abnormalities and X-rays are very, very common in asymptomatic people. So CAM morphology does not mean CAM impingement. Tensor morphology does not mean tensor impingement. Impingement is a clinical diagnosis. Even as simple as slip angle, it varies with the type of lateral you get, right? So none of these are very accurate. And AP and lateral views may show a perfect head neck junction, but you may have your CAM bump in between. So a CT scan will show you the CAM bump. That's anterolateral. And then femoral anteversion influences all the effect of all the others. So femoral anteversion can compensate for CAM morphology and not let it impinge. Or acetabular dysplasia can compensate for CAM morphology and won't let it impinge. So none of the findings are diagnostic of FAI. FAI is a clinical diagnosis. So a few clinical types. So decreased FAR with a clear bony block, I told you, is a clear impingement. There'll be reproducible pain. There's an example of somebody with limited motion without reproducible pain, but the treatment is the same. You confirm the diagnosis with an injection in this patient, and then you're going to treat him. These are confusing. Pain with impingement testing, but they have more range of motion without a bony block. This is almost always from a small CAM that's going into the hip and not obstructing range of motion. So this is a little tricky. You need to get an MRI and all these and rule out other pathology before you say it's the CAM morphology. This CAM is very, very common. Most of us have CAM morphology, and but not impinged. So case example, the majority of mine are anterior FAI, a spherical femoral head, lack of offset, an impingement groove in the front, CAM bump, cam osteoplasty, took care of her, right? Arthroscopically done osteoplasty. A little overdone. I don't need to dissect that much, but he did okay. The SCEPI, again, obvious impingement. There's a little prominence here. Do the osteoplasty after putting a screw in. Type 2, they don't have any pain, so you give an injection. They have pain only when they run. Your exam is not causing pain. These people get an injection to the hip and they go run, and this come and report to you if the pain is gone and the injection is working. Then you do the same impingement treatment. Again, a spherical head, osteoplasty. This patient with good range of motion. So you're not sure if it's impingement or not. So you ruled out other pathology with a careful exam, MRI scan, whatever you need. Usually a very small cam bump and maybe show mild dysplasia. Again, an MRI routinely, like I said, and then I want to make sure that there's no labral hypertrophy. Labral hypertrophy is a sign of dysplasia. I want to make sure that's not dysplasia causing it. It's the cam bump, and then you take care of the cam bump. Again, same treatment, little bump in the front. MRI is negative for anything else, osteoplasty. Last patient, I couldn't tell on clinical exam or MRI. They go to the operating room, old perthes, mild deformity. I couldn't tell if it's impinging or not. So took him to the operating room, and he had a little labral tear and a small little bump that's correlating with it. So cam osteoplasty and labral repair. Right there. So I'm going to skip this results part because I want to show you a few case examples. Okay, here. So I talked about crossover sign. A crossover sign is anterior coverage posterior deficiency through retroversion. The treatment is antiverting PIO, right? We went through all this. I'll show you case examples here. Here's a retroverted acetabulum. Ideally, you should get antiverting PIO, right? Anterior coverage, arthroscopic rim trimming and osteoplasty. Overcovered, really overcovered, but no medial dysplasia. So I can remove all this bone on the lateral side and won't cause any instability or problem. So I measured all my angles. My goal is to decrease the rim from here to here. Did the osteoplasty and took out that much bone. So 90% coverage became now about 40% coverage anterior wall, and these symptoms are resolved. Here's a crossover sign with posterior deficiency superiorly, so true retroversion. MRI did not show any other pathology. Got an anti-verting PIO. The acetabulum was loosened up and turned anteriorly, and the posterior coverage is now more than 50%. Anterior coverage became less than 30 or 40%, so it's not impinging anymore. A severe retroversion. This is an extrophy patient. You can't even see an AP view, you can't see even the posterior wall anywhere. On oblique view, you can see a big crossover sign. Got an anti-verting PIO, ignoring the extrophy. He was doing okay with that. So we just turned the acetabulum so the posterior dysplasia is corrected. So my current approach, anterior FAI is a clinical diagnosis. Treatment is based on radiographs. Labral tear is an early finding of hip disease, not the diagnosis. Right? So don't repair the labrum without knowing the cause and treating the cause, because labral tears, we may say a labral tear from trauma, but labral tear from trauma also has some underlying cause. Like I told you, most dislocations happen from anterior impingement, just like that most labral tears happen from impingement if there's no dysplasia. So treat the underlying bony cause, not just repair the labrum. So video to show you this arthroscopic treatment. Acetabulum, femoral head, distracted. You need distracted to get into the hip. So I got my portal in, cutting the capsule to make it easy to go in and out. The capsulotomy is being done. Switch the scope to the other portal, completing the capsulotomy. That's iliacus muscle, psoas tendon. They cut all the way to the psoas tendon. So it's very easy to do a psoas tenotomy if I have to, but almost never do it in FAI. Only in total hips with painful tendinitis. So now look at the labrum. Tensor labrum all crushed. I know my diagnosis, impingement. So look around the hip. That's a developmental variant, a little scar of the bicep, palpating that on the labrum, pincer. Establishment. Pasa. So we're taking the rim of the establishment down. I measured how much I can take. Bone is 5.5 millimeters. I'm taking about 5 millimeters of bone from the establishment rim. That will give me about 10 to 15 degrees of internal rotation, flexion internal rotation. So she was 0 to start with. So this will give me about 10 to 15 degrees right there from the rim pyramid. So after the bone is trimmed or resected, I chose not to debride any of that loose labrum. I wrapped it all up into one mass. And reapproximated this complex to the establishment. That's a whole anchor going in. Now the labral tissue is not falling in anymore. It's all wrapped up against the newly formed establishment rim. So that's first anchor. Typically do 2 to 3 anchors to repair. So 2 anchor repair done. Now the traction is off. This is the head. Look at the red spot where the labrum is impinging. And this is the cam morphology. Look at how far the cartilage is going. So that's cam. And you need to remove from here to there. So same burr, 5.5 millimeters. I use fluoroscopy as needed to make sure that I'm medial enough, not leaving any sphericity of the head.
So most of the work is orthoscopic.
And you can do this open easily. So nothing that's done arthroscopically cannot be done open. So we're taking the cam osteoplasty all the way to the lateral aspect. And then we repair the labrum, the capsule back.
Okay.
That's an impingement cyst. It's a fibrous tissue in the bone.
And what is the immediate benefit all these patients get?
Just want to show you one case example at the last. 60-year-old lady came to me with impingement. I treated her with FAI. She had genu valgum and knee arthritis. The leg was shorter. When she got a total hip done, the leg was aligned. Now my rim trimming made this hip unstable, made it more dysplastic because the leg is now not short anymore. Coverage is less, and she was having pain of instability. So she was feeling better when she was turning her toes in, so the head is not coming out anteriorly. So my rim trimming that was appropriate before the total knee became inappropriate after the total knee. Thank you very much. Dr. Chandak, I can't hear you guys talking, so I'm going to sign out and sign back in.
Yeah, that would be better. So all of us need coffee now.
Yes, sir.
Because I can't hear anybody.
So Manoj, your reaction after listening to the cam morphology and the pincer morphology, are we missing all these cases in our opinion? Is it existent? Are we missing them? What is your feeling?
So obviously, if those conditions, if the hip pain remains undiagnosed, and then we need to go for another diagnosis, which then the routine which we find in our clinical scenario, like the avians or sometimes synovitis infection. So in those cases, maybe sometimes this routine pelvis X-ray, where sometimes we can see those bumps, and then only we drag into attending whether this could be one of the reasons.
I still can't hear anybody.
So are you muted, or can you join from your cell phone?
Dr. Chandak, can you call me on the phone so that I can answer to you?
Yeah.
I'm not able to hear anybody.
You can write in the chat box. I don't know why.
So are we Indians more
Guys, I can't
adapted?
hear anybody. Can you call me on the phone?
Yeah, we are doing that, sir. If I don't know whether he is.
Dr. Gadigone, have you seen patients of FAI?
My practice, I may be not understanding what exactly it is because I failed to find cases of this scam in my practice. Very few cases I came across. So probably we are not able to diagnose it one, or actually we are ignorant of this condition.
Same with Sankeet?
What is your thought? What is your thought process?
I can't hear anybody. Yeah.
Are we more adaptable?
Yeah.
I think it's usually a secondary diagnosis because all other hip pathologies are more common. So sometimes the MRI diagnosis which patient comes with directly, like the MRI is showing all these things, and sometimes we are missing out it clinically as well.
Okay.
So I think whatever the signs and symptoms which Dr. Prasad has told will certainly very beneficial, at least in diagnosing this kind of. Usually we try to go for an external rotation test mostly because of the AVN, where the early this posterior superior head impingement we like to see. But the internal rotation and the extension test which you are told, I think we are usually missing on those tests with our routine hip clinical examination.
So Manoj, there is a question. What is the role of physiotherapy in FAI? So Prasad, can you answer that question?
Yes, yes. It's okay. It's okay to try physiotherapy. No harm as long as it's restricted to strengthening and pain relief measures. Almost everybody gets better short term, but it does not fix the impingement. There is a passion trial from UK that showed that surgery has higher success rate than non-operative measures. And people who go to non-operative measures have to modify their activities and live with some pain.
Okay.
So that might be the reason that our patients may not come up frequently with again and again with the hip pain. They might have modified themselves after our primary conservative. Can that be possible?
Could be one
I
of
didn't get
the
the question.
Yeah,
So,
because
another question to you, Dr. Prasad, is there implication of FAI on THR and surgical tips to protect dislocations in such cases?
Yes, obviously. I mean, your whole idea of placing the cup and having a bigger head is to decrease the risk of impingement.
Okay. So Dr. Amol Kadu has commented, it seems like a lot of FAI in practice, you only see what you know. Maybe after this talk, we'll change the vision of my reading of X-rays. Any comment on that?
More than X-ray, start examining them more carefully. My hip exam takes less than 2 minutes actually. You can master hip exam for routine screening exam. Probably in a minute you can flex up, bring them to 90 degrees, internally rotate, check the range, press them to see if there's pain, do a favor test, and you can pretty much screen out the hip for impingement.
Okay. Okay. Thank you so much. These were the questions in chat box. And Asim, any question to Prasad, if you had?
A lot.
Okay.
We'll start reading about it now more.
Dr. Asim is commenting that we'll start reading more about FAI. Any questions from Alok, Manoj, Sangeet?
That is also true for me. Actually, probably after this lecture, I will be more wiser in diagnosing this.
So my question to you, Prasad, Dr. Prasad, is after treating fracture neck femur, many of these patients develop change in the femoral head and neck shapes. Will this patient be having pain and limb because of the developed FAI or the CAM or the impingement? Will they have all this?
Yes. Because on lateral view, if you see callus in the front and the offset is gone, they can impinge. It's like cam morphology. But the
Okay.
diagnosis is impingement is clinical. Decreased motion with pain, reproducible with your impingement testing. And there's a case report of a non-union of a femoral neck from recurrent impingement because the stress on the fracture was so much with the impingement every time they sit, the fracture was not healing. And after osteoplasty, the fracture healed.
Okay. Thank you so much. Any question from you, Alok?
Sir, I think we need to be more clinically sound to examine all these cases which sir has put. I am thinking that our patients more adaptable to, like after a conservative line of management, they don't turn up again with the hip pain. So they might have modified, or maybe we are missing them in OPD.
Okay. Possible. So Aditya, you had any question you can ask?
Aditya, you are
You're
muted.
muted.
Aditya, you are muted.
Yes, sir. Yes, sir.
Yeah. You
Sir,
had
I
any
have
question?
yes, sir. Question to Prasad, sir. That he said bigger heads are the implications for the impingement. So, what should be the ideal size for head while we are going for the THR? And as he said that there are retroversions in the pelvis. So, in every case, we need to identify them preoperatively if we are suspecting the FAI and we are going ahead with THR.
Well, with THR, the bigger heads are better. So 36 is probably stabler than a 22 head for sure. But it all depends on the established site that accommodates the bigger head. And you want to make sure your version is appropriately placed, looking at the tarsal ligament in the bottom. But if somebody has spinopelvic pathology, limited motion, you need to be extra careful to figure out if the pelvis is fixed in sitting or standing.
Yes, sir.
And then modify your cup placement based on that. A mobile spine, you're safe.
Okay. Thank you so much, Dr. Prasad. So, Harshwardhan, any comments from your side after listening to radiology and MRI discussion and the treatment protocols? As radiologists, you see.
One thing I would like to change in my approach is looking at the X-rays in detail, what we have been taught today, and then having a look at MRI so that we can give a more complete diagnosis. And obviously, clinical examination has no replacement.
So you keep crossing over from imaging to radiology and then imaging.
Yeah.
Okay.
Harshwardhan.
Yeah, sir.
At Indore, where I get my MRIs, Dr. Manish Agrawal is there. He has his technicians. They will scan the clinical notes which I send. They will take photograph of the X-rays and even the clinical photograph of the patient also. And everything is provided to him. Clinical photograph also. Suppose there is a tumor, suppose there is a scarred skin, there is a deformed leg or foot. So all that information, technician photographs and it's recorded and sent to him. Ideally, I should talk to him. Most of the time, I am talking to him.
That's great to hear, sir. I think the radiology is blessed to have so much of clinical information.
So train your technicians to take clinical photographs, X-rays, and clinical note which we send after examination.
Thank you so much. Sangeet, if you can draw your opinion to this topic or your experiences, please come in. So he's there.
Sangeet sir has commented. Sangeet sir has given the best comment. Like if the Prasad would have left us ignorant, it would have been much better. Too much of good information. I think.
No, it has sparked that discussion now. So
yeah,
after 1 year, when Prasad comes back, I think many of us will be more knowledgeable about what he's talking.
Yes. So
most of you are on the group anyway.
An eye-opener.
When you see the hip X-rays, now we're going to pay attention. We can discuss more. When I point out subluxation on that last X-ray from the osteochondroma, you now appreciate it when you go back and look at the same X-ray.
Yes. So this is almost 7 p.m. Thank you everyone for joining in. That was wonderful discussion. And we thank you, Dr. Prasad and Dr. Harshwardhan, for giving all the inputs on FAI. I think next X-rays we look forward, we'll be seeing sourcil more closely. We'll be seeing phobia more closely and all those angles. And at least in some cases where we suspect FAI, we'll be drawing all those angles. Thank you very much.
It's not crucial to draw the angles. You'll be able to eyeball and say, is it medial deficient or not deficient?
Yes, yes.
You don't need the exact angle. You'll be able to eyeball it really easily.
Yes. Yeah. Thank you so much for bringing all those insights into it, and we'll be interacting more. I think this source of information will be very useful to all the listeners on Ortho TV. And since this is a recorded thing available for them for a ready reckoner later on, it would be a very useful source of information. Alok, your final comments. Manoj, your final comments, and I think that will close down the.
We had a fantastic discussion from diagnosing, from knowing the normal anatomy of the hip, pelvis, reading the pelvis, inlet, outlet. Never thought of the 2 to 3 centimeters, but what sir told was true. And having adequate knowledge now, maybe in our OPD, we may be more alert to diagnose FAI now. And treatment as such, I would be more keen because I don't do hip arthroscopy. We would like to know more about open procedures, how we can manage them.
Yes.
Well, we're having a course. POSI has a course on July 1st in Bangalore, cadaveric course.
Okay.
And we'll have a Hamara course in December, discussing open procedures for a whole day.
Okay.
Right?
Good.
I'll put the information in when it's ready.
Yeah, good to know that.
With us also.
Yeah. So with this, I think it's our time to close down this webinar. Thank
Prasad,
you.
when is the Bangalore course?
I think Ramaya cadaver.
When is that? When is that?
Date, Prasad? Which is the date?
July 1st through POSI. You have to go to the POSI website.
Okay.
And Tirupati?
Tirupati will be December 8, 9, and 10.
Okay, thanks.
Great.
So thank you everyone for joining
Good
in.
night.
So thanks Prasad, thanks Harshwardhan. Thank you all the panelists and thank you all the moderators and delegates. It was wonderful listening to this webinar. Thank you Ortho TV, and we'll be closing down this webinar.
Very useful information, sir.
Yeah, it was very useful. Very useful. And see, at least we know now what to do. And Ortho TV, have we stopped recording?
I think they are still there.
So do we call them to stop?
Yes, sir. Yeah, screen height.
I'll call up Ashok.
There are only 4 of us, sir. Dr. Gaurang Agrawal is there.
Yeah, Dr. Gaurang is in. Gaurang, your opinion?
I think he has now. Manoj is also there.
Manoj also is left. So I'll inform.
Start, sir.
Hello, sir. Is there anything I can help you with?
So we can stop the recording and stop the webinar. We have already finished the discussion. Thank you so much.
All right, sir. Thank you very much.
Yeah. So I think, Alok, that was wonderful. And next topic we take up, we can take up from Ortho, our new venture, or to the JCO, whatever you feel like. Yeah.
Sir, the new one, we can just start utilizing that platform.
Yes.
And yeah, something on the say common topics.
Yeah, okay, absolutely fine. I have requested Dr. Radiologist from Mumbai to come in. He has requested for a weekday, so we'll take any good interesting topic from him. That would be one, or What topic should it keep up? I think we'll discuss on group and we'll take up those topics.
Yeah.
Right?
Sir, knee MRI will also be a very radiologist is coming. Knee MRI, people find it difficult to interpret.
Okay, so we'll discuss on knee MRI as well, right? Interactive discussion on knee MRI. Sure. Thank you so much, Alok, for thank you.